Well, my name is Julia Berman, and today I'm going to be sharing a little bit about Crohn's disease. So let me just share my screen really quick. All right, I hope everyone can see this okay. So today I'm going to be discussing Crohn's disease. So first off, what is Crohn's disease exactly? Crohn's disease affects the gastrointestinal system. It involves the inflammation of the GI tract. As you can see here, inflammation occurs in the colon, the small intestine, and the rectum. And it affects like the entire bowel and can be moderate to severe. It requires significant medical intervention in most cases, but can also go into remission with proper treatment. So there's many different factors. It can either be in like remission or it can be in progression where it gets worse. I'm going to talk more about that in the future slides. So first, a brief history of Crohn's disease. It was first observed by Soranus of Epicurus, who was a Greek physician in the 2nd century AD. In 1769, Dr. Morgione performed an autopsy on a 34-year-old who had presentation and inflammation in the bowel consistent with Crohn's disease. At this time, the disease was not yet named, but the symptoms were the presentation was what Crohn's disease is today. In 1813, Dr. Combe and Dr. Saunders at the Royal College of Physicians again identified a case with the inflammatory symptoms consistent with Crohn's disease. In 1828, Dr. Abercrombie observed a 13-year-old girl with Crohn's disease symptoms. This sort of illustrated historically how this presentation of Crohn's disease can vary in ages. For instance, we have a 34-year-old and now a 13-year-old child with symptoms of Crohn's disease. In 1859, Dr. Samuel Wilkes observed what was then called idiopathic colitis, which was basically the inflammation of the bowel consistent with Crohn's disease today. So from 1959 to 1932, more cases were reported of these inflammatory biomarkers present in the bowel. And in 1932, this was known as regional ileitis, and the disease was officially named after 3 co-authors who initially studied the disease. Dr. Crohn, which is who Crohn's disease is named after, and his co-authors were Dr. Ginsburg and Dr. Oppenheimer. Here in this image, you can see Dr. Crohn, Dr. Ginsburg, and Dr. Oppenheimer. So from 1932 to the present, there have been many new developments in the treatment of Crohn's disease. It has now become like easier to identify as more and more cases are studied more in depth and researched. Because throughout history, the sort of vague symptoms made Crohn's disease difficult to identify. A lot of the symptoms are consistent with many other conditions. There are many more inflammatory bowel conditions that have similar symptoms to Crohn's disease, but the inflammation patterns are kind of unique in Crohn's disease. And today there have been new developments and new clinical trials are consistently being conducted to help patients with Crohn's live a better quality of life. So I want to talk about just briefly the biological and physical presentation of Crohn's disease. As you can see here in this image, Crohn's disease really sort of affects the tissue of the bowel. You can see here there's a thickened wall of the tissue, and here are the epithelial cells kind of abnormal architecture shown in the epithelial cells in Crohn's disease. And you really see like it's often diagnosed via scope such as a colonoscopy, and you can see sort of like this cobblestoning pattern and pseudopolyps forming, which are basically like inflammation in the bowel. And it's important to have these tests done to identify and differentiate Crohn's from other medical conditions. And it's both genetic and environmental in its presentation. There are certain genes associated with Crohn's disease, such as NOD2 and ATGI6L1 and IRGM, which are sort of seen and affected by the Crohn's disease. And it's been, although it's not primarily genetic, it's been shown that the families with Crohn's disease have like a higher instance of passing it down to their children than families not affected by Crohn's disease. And it's also interesting to consider how the biological mechanism behind Crohn's disease is also quite environmental. The gut microbiota, each individual has a unique microbiome in the gut. And this is altered in Crohn's disease. Many different environmental conditions can lead to this alteration of the microbiome, such as the food we eat, the environment we live in, different toxins present in the environment, and even like prolonged antibiotic use can destroy the gut microbiota and drastically alter its composition. And this is just showing sort of the anatomy and physiology of Crohn's. You can see like there's a thickening of the colon wall, that cobblestone appearance on the surface, which makes Crohn's kind of easy to identify via a scope. And also fistulas are present in Crohn's. So the symptoms of Crohn's, as I mentioned before, are often symptoms that are associated with many other medical conditions, varying widely in severity. The symptoms of Crohn's are often mild, moderate to severe, and require significant medical treatment. They include some basic ones are diarrhea, pain in the abdomen, fatigue, destruction of the small intestine, malnutrition, changes in weight, and bleeding in the rectum. And so I just want to go over briefly the epidemiology of Crohn's disease. It's very common in Northern Europe, North America, and New Zealand, as opposed to other nations, as you can see on this map here. So it's kind of interesting to consider how this disease is more prevalent in one region of the world than others. And it sort of begs the question as to whether the environmental conditions of these regions of the world, they're mainly in the northern hemisphere, if they somehow impact the gut microbiome, which lead to the presentation of Crohn's disease. And it also, as discussed before, has genetic and environmental factors such as those specific genes that are often affected in Crohn's disease, in association with the development of Crohn's, with other family members having Crohn's. That should always be taken into account in a medical history of an individual displaying the symptoms of Crohn's. Their family history should be taken to identify presence of Crohn's or other inflammatory bowel conditions in the family. And it only affects 0.5 to 1% of the population. However, this is more common than other diseases. We've discussed Duchenne Muscular Dystrophy, or DMD, extensively in this course, and that affects roughly 1 to 5,000 births are affected by that. You can see that that's a much less common disorder than Crohn's disease. And Crohn's can often present later in life. It's not just present at birth. So there's more of a wide range of ages that it's diagnosed at compared to DMD, which is often diagnosed in early childhood. And DMD is highly genetic. It's an X-linked, sex-linked genetic disorder. So there are many different treatments for Crohn's disease. They kind of vary widely in the like invasive nature of the treatment and also importantly the cost of the treatment. There's often medications such as corticosteroids like prednisone, which help reduce the inflammation, mitigate the symptoms. Prednisone is also used in DMD to treat the inflammation associated with that disease. Immunosuppressants are often used in the treatment of Crohn's. Some examples include methotrexate, which is actually a chemotherapy drug, but it's often given in smaller doses to Crohn's patients to sort of suppress the immune system. And Humira, which is an injectable therapy which suppresses the immune system. And anti-tumor necrosis factor, or TNF. TNFs are basically a factor which causes, when elevated, such as in Crohn's, causes the immune system to essentially attack itself and cause inflammation. These anti-TNF drugs, such as infliximab and adalimumab, can help suppress the immune system. This is actually adalimumab is the generic form of Humira. So Humira is both an immunosuppressant and an anti-TNF drug. There are also anti-inflammatory drugs that can help mitigate the symptoms, and antibiotics are used, such as clindamycin and erythromycin and amoxicillin are used to treat the symptoms of Crohn's and can help with associated infections with Crohn's. But it's important to understand that they also impact negatively the microbiome of the gut, which can actually make the disease worse in the long term. And additionally, anti-diarrheal medications like Imodium is a common one, and pain medication is often used like after surgeries, especially treatments and during flare-ups, such as non-steroidal anti-inflammatory drugs like Tylenol and Advil. For more severe pain, opioids are used, such as morphine. And surgical procedures can often help Crohn's, or are often needed, especially when the disease is in later stages and in progression. And they can include drainage of like associated abscesses and fistula repair surgery, bowel resection. This can happen like in the small intestine. For instance, like basically like a small portion is removed and is kind of sewed together to sort of the really damaged portion is removed to help decrease the presence of disease in the body. Fistula repair, and then ileostomy is sort of one of the last resort surgical options because it's an invasive procedure. And so these sort of the bowel resections are considered first before the more invasive ileostomy. And it's important to incorporate lifestyle changes and a multidisciplinary active method of care and treatment of diseases such as Crohn's disease and also DMD, as discussed in this course. Nutritional supplements like different vitamins, because Crohn's disease, having this inflamed colon, negatively affects the uptake of nutrients in food. So supplementing with vitamins and minerals can greatly assist that. And also lifestyle and dietary changes, eating like more healthful foods that many different factors in the traditional American diet, such as like fried foods and unhealthy foods with a lot of sugar can increase inflammation, and changing the diet can drastically help those environmental factors of Crohn's disease. And in DMD, also lifestyle and dietary changes are recommended to help mitigate the symptoms of DMD and reduce strain on the heart and respiratory system, which can help mitigate like DMD associated cardiomyopathy and respiratory failure. So in what other ways is Crohn's disease similar to or different from Duchenne muscular dystrophy? So again, in this class, we discussed Duchenne muscular dystrophy in depth. It's interesting to consider the similarities and differences of Crohn's disease and Duchenne muscular dystrophy, because one is DMD is like a disorder of the skeletal muscle, while Crohn's affects the gastrointestinal tract. So at first glance, it might seem like they're widely different disorders. However, they share many similarities. Both DMD and Crohn's involve inflammation and an impaired immune response, which leads to increased inflammation. So you see like similar treatment mechanisms like steroids and anti-inflammatory drugs to really help with the pain and symptoms caused by inflammation in both DMD and Crohn's. For instance, steroids like prednisone really can help the symptoms of DMD and Crohn's. However, they're not without side effects. Steroid medication often includes severe side effects like impaired puberty, especially when given to adolescents and children with these diseases, and also it can cause weight gain. And it's important to be informed of the side effects before starting any medication. And also there are similar clinical trials. For DMD, many clinical trials focus on gene therapy, such as exon skipping therapy and adeno-associated viral vector gene replacement therapy, as well as stem cell therapy are many of the therapies being considered in clinical trials today. However, since Crohn's is the sort of association with Crohn's and genetics is more vague and less is known about that. Crohn's is more of an interplay between genetics and environment. Most of the studies for Crohn's focus more on like stem cell trials and anti-inflammatory medications, such as anti-TNF medications. There's less gene therapy trials for Crohn's relative to DMD. And in addition to the similarities, there are many differences. DMD affects the skeletal muscle tissue, while Crohn's affects the bowel and GI tract. There are differences in treatments indicated for DMD versus Crohn's. Although there are a lot of similarities, DMD is often treated by more like gene therapy drugs and also more like medications to help like reduce strain on the heart and maintain heart health, as well as maintain respiratory health. Because in DMD, kind of the altered dystrophin expression leads to this progressive muscle disorder, whereas Crohn's is more like localized inflammation in the bowel. DMD sort of affects all skeletal muscles and affects muscles such as the heart and the diaphragm, which is greatly involved in respiratory function. And then DMD, as we discussed before, is mostly genetic. It's an X-linked disorder, which is inherited from the parents, more common in boys because they only have one X chromosome, while girls have and women have two, so it's more common in boys. And whilst Crohn's disease is more of a weak association with genetics and has a larger environmental component, and DMD is often like occurs really early in life, in early childhood, and it often is terminal. Many DMD patients only live until like adolescence or their early 20s, whereas Crohn's disease can present later in life and can be like triggered by certain environmental changes, and is not often terminal, um, much less terminal than Duchenne muscular dystrophy. And also, it's important to note that both DMD and Crohn's disease should be treated with a multidisciplinary aspect of care. For instance, like multiple physicians, like not just having like a primary care physician or like a limited number of specialties, but they should be like treated with multiple different specialties, and it should be a holistic approach to care, focusing on like daily life and non-pharmaceutical interventions in addition to pharmaceutical interventions, for instance. And the multidisciplinary care looks a little bit different for DMD versus Crohn's. DMD, you want to have a cardiologist and a pulmonologist to monitor the heart and pulmonary function, as well as a geneticist and orthopedist and physical therapists, even social workers to help counsel parents on the disorder, as well as, of course, a primary care physician. And there's some, for DMD, like in addition to just medications, there should be like a BiPAP or CPAP machine can help with the respiratory function, and really just changes in diet and lifestyle choices can help and should be discussed with patients. And then in Crohn's disease, there should be like a gastroenterologist, a geneticist, a nutritionist, perhaps, to like focus on the lifestyle changes and nutritional needs. Also like a physical therapist, social worker, can be helpful in the multidisciplinary care for Crohn's, as well as Crohn's can benefit from non-pharmaceutical interventions like different nutritional supplements, probiotic supplements, in severe cases, ileostomy surgery and the use of ostomy bags, and also just really considering like incorporating more exercise as tolerated, and the lifestyle changes. It's important to note in conclusion that both DMD and Crohn's contain treatments which range from can be really costly to the patients and their caregivers and their families. This is also a potential theory as to why it's more commonly diagnosed in the Northern Hemisphere as in more developing parts of the world, more developed parts of the world, like North America and Europe. The diagnosis of Crohn's often requires costly testing, such as like a colonoscopy, which might not be as accessible in other parts of the world, like such as in developing nations. And the treatments for both DMD and Crohn's often are costly. So individuals of a lower socioeconomic status may face issues with accessibility in healthcare in this aspect. All right, so I want to sort of conclude with a case study now. This is my father, right over here, Dale Berman. So basically, when my father was around age 14, he started experiencing stomach pains with high fevers and lots of nausea. It sort of came and went. So his doctors weren't so concerned because, these are symptoms of many different disorders, different gastrointestinal disorders. It can be serious, like those are symptoms of some cancers, but it can also be pretty benign. It can even be symptoms of life stress or anxiety. So he was brought to 3 different doctors, and they didn't really do a lot of testing because there are such generic symptoms. However, when my father was 17, he went off to college in Reno, and became very sick a few months, and he had a very high temperature of 106, and was constantly vomiting, and lost a significant amount of weight, nearly 30 pounds. He was like in very grave condition at that point. So he flew back to his home in Los Angeles, and had to go to the hospital for a week. Again, they sort of dismissed any further testing and stated it was likely a virus. So they treated him for like a virus. And however, eventually, because it wasn't improving with traditional treatment for a virus, they did like a battery of tests on his stomach and GI tract, and they said that he had something called ileitis, which is basically like inflammation of the bowel tract. And then he was basically diagnosed with Crohn's, because after imaging studies and scopes studies, they basically told him that he has Crohn's based on the presentation of the imaging, and there is essentially no cure. In December of 1975, my dad's intestines sort of closed up completely, and he had to get urgent treatment at that point. He had a lot of pain. He actually came into the hospital at UCLA for a small intestine resection surgery, which you can see sort of illustrated in this image below. And he had to be hospitalized for a while due to like post-surgical complications and high fevers, and had to be in an isolation room, which he describes as a very strange and surreal experience. However, I'm grateful that he was able to get the proper treatment at the UCLA hospital. So after his diagnosis and the initial surgeries, he was put on like steroid treatment, high dose prednisone for the inflammation, Humira injections every 2 weeks he has to take to continue on the immunosuppressant effects. This immunosuppression also makes him susceptible to certain viral and bacterial infections. So he has to be like careful due to the side effects of this drug. He also was given Question powder after his surgery, which helps inflammation. It's an anti-inflammatory, and sulfazine and antibiotics after the surgery to help with the infections and complications, and opioids were given for pain after this surgery. It's important to know that these aren't long-term treatment options due to their side effects and addictive nature, but they are really important in reducing pain, especially like post-surgery and during flare-ups. And then also he takes Imodium frequently, which is basically just an antidiarrheal medication. And then it's important to note that a common comorbidity with Crohn's, because of the lack of absorption in the intestines, is kidney stones due to the oxalate buildup. He gets kidney stones frequently. He's often hospitalized for them. Around 2010 is when he had his first experience with kidney stones. They're very painful, and even in the last year, he had to have 5 surgeries to get them out. So it's a very significant sort of comorbidity with Crohn. So it should be monitored by a nephrologist, a kidney doctor, which can help mitigate the symptoms of this important comorbidity with Crohn's. So basically today, to treat the kidney stones, he has to be given large doses of potassium, which is one of those supplements that we discussed earlier, the nutritional supplements that can really help in this sense, not just with the Crohn's and inflammation, but also the kidney issues. So far, this has worked well for him. He still has to have an x-ray every month to monitor the stone growth and to check, because potassium, even nutritional supplements, are not without side effects. Too much potassium can greatly damage the heart. So he has an x-ray monthly to monitor that. So Crohn's really, and the potassium seems to be working so far. Crohn's drastically impacts my father's life. He often can't do the things he loves to do because he is often affected by his symptoms of Crohn's. Throughout his life, he has gone into periods of remission where his disease is much less severe, and periods of like flare-ups where it's really severe, like he's needed multiple like bowel resection surgeries during the flare-ups, which has greatly affected his life. He's also had to deal with medication daily, which is not without its side effects, which can also greatly affect like his demeanor and his quality of life. And so as his doctors say, there's no cure for Crohn's disease, as there is no cure for DMD, as we discussed in this course. So this really highlights the importance of clinical trials, because these treatments are often costly. They're often have severe side effects, steroids with the weight gain and the issues with puberty, and opioids with to mitigate the pain, which cause severe like respiratory issues, other side effects, and most importantly, there's a side effect of the risk of addiction. And often the tests and treatments for Crohn's are very invasive, like bowel resection surgeries, kidney stone surgeries, in some patients, ileostomy surgery, which requires great care and is very invasive. Hospitalizations are required. So this highlights the importance of clinical trials to help people like my father. There may never be a cure discovered for diseases such as Crohn's and DMD. However, different clinical trials can really go beyond the scope of traditional pharmaceutical medications and non-pharmaceutical interventions, and helping to increase the quality of life and lifespan for individuals with diseases such as Crohn's and DMD. So it's very important to continue furthering the research for diseases such as Crohn's and DMD. So the future of Crohn's disease research, in my opinion, involves continuation of current pharmaceutical and non-pharmaceutical interventions, if clinically indicated, as well as surgical interventions. However, the future of Crohn's disease also looks like continuing the research on current clinical trials, analyzing what went wrong in previous clinical trials, which didn't have such great success, and sort of developing and refining more effective treatments. Some clinical trials today include the trial of human umbilical cord mesenchymal stem cells. The idea is that stem cells can basically are cells which can differentiate into multiple different types of tissues. Some can differentiate into all types of tissues. Some are more specialized. So the idea is that these stem cells can sort of differentiate into healthy epithelial cells and tissue of the bowels, and can sort of replace those damaged, inflamed cells in the colon for Crohn's. However, there are some issues with this therapy. For instance, the stem cells are often derived, like in this trial, from umbilical cord of the often when the child was born or from a different source of umbilical cord stem cells. Not every parent has the resources or ethically wants to save the umbilical cord blood of the child and obtaining it from other children. There's some risks inherent in that are not fully known, and there's ethical concerns. Other stem cell types can be derived from embryos, often aborted fetuses, which creates some controversy and the ethics and behind this therapy. Many religions are, for instance, against abortion, which can create issues. And this is sort of a future trial. It's not started yet, but in the future, it will begin to help research the effect of stem cells on Crohn's. And then also there is the drug ABBV-154, which is a glucocorticoid modulator receptor, which is currently recruiting this trial. And it's basically sort of modulates the function of these glucocorticoids, which are involved in the inflammation present in DMD and the inflammation in Crohn's and the symptoms of Crohn's. So this can sort of modulate the effects of these glucocorticoids and hopefully reduce the symptoms of Crohn's. Additionally, the antamolibab monoclonal antibody was a study that was completed. Basically, this monoclonal antibody was aimed at targeting the inflammation and symptoms of Crohn's, and it was discontinued actually in 2020 because the results of the clinical trial were fairly insignificant and not as powerful and significant statistically as was hoped. So this highlights the idea of kind of going back, analyzing what went well, what went wrong in this trial, and what can be done to maybe try again with a similar therapy in the future with refinements, and kind of to go back and revise treatments throughout the clinical trial and research process. And one really interesting possible treatment of Crohn's is the idea of fecal transplantation. So this is essentially taking the healthy fecal matter with the healthy gut microbiome, most importantly, from another individual, and sort of introducing that into patients via colonoscopy, which can be sort of invasive, and there are ethical concerns with that. However, recently there have been scientists have worked on different pills that basically contain the encapsulated fecal matter, which Crohn's patients would just take orally, which would be a much easier delivery mechanism, and but still has its ethical concerns. Often in fecal matter, there are different types of bacteria, such as E. coli, which must be taken into account. However, the idea of fecal transplantation is that the gut microbiome associated with Crohn's that is dysfunctional can be restored to a normal, healthy level. So to compare Crohn's to DMD once more, both Crohn's and DMD have the stem cell trials going on with stem cells. So stem cells are sort of a newer technology, the transplantation of stem cells. And this holds great promise for the future of healthcare because basically stem cells can differentiate and become healthy cells from multiple different tissues. So it can be applied in multiple areas of research. However, we see with Crohn's, there are more anti-inflammatories and therapies targeting the microbiome, the fecal transplantation, whereas in DMD, there's gene therapy is a common therapy we see in clinical trials and current research due to the highly genetic component of DMD. For instance, we see exon skipping therapy and gene replacement therapy. So to conclude, it is important to incorporate a multidisciplinary, comprehensive aspect of care into complex diseases such as Crohn's and DMD. And it's really important that scientists develop more effective treatment for these diseases which have no cure, supposedly, such as Crohn's and DMD. Even if a cure is not found, these treatments can greatly impact and improve the quality of life and lifespan of patients with complex diseases. So it's up to us and the scientists to develop new therapies through clinical trials and continued research, and to refine and revise current therapies, both the ones that didn't do quite so well in the initial trials and the ones that did do well in addition. In doing so, we can greatly impact the quality of life and lifespan of patients with complex life-altering diseases such as Crohn's and DMD. And here are my references I used in this presentation, and thank you so much for watching.